Hello. Start. That is the my dear students. Very good afternoon. So the today's lecture is the basics of pacemaker, and I am Dr. Mustafizur Rahman, Assistant Professor of Cardiac Electrophysiology of NICVD, is going to taking the lecture, and the device therapy is a very wide and broad area in the electrophysiology. And the pacemaker is one of them, and this is not that much easier to understand in a short lecture or in a very quick session. It's a very long learning curve, and it will take a time to understand all the basics. Basics are always is difficult, so you have to give more concentration to understand the all the basics of pacemaker. I will try my best to make you understand all the basics of the pacemakers one by one, step by step. So before going to the lecture, let us see that what are our learning objectives in the pacemaker basics. That is the one. We have to understand the pacemaker components first. What are the components of the pacemaker systems? And the pacemaker basic functions. What are the basic functions and the types of pacemakers? And pacemaker codes and modes. And some electrical concepts, as is the electrical device. So the electrical concepts should be understood by everybody. And the timing cycle, pacemaker timing cycle, by which it maintains its function. And later on the indications of the pacemakers, and so that is the implantation procedures, and some of the complications are also included in the basics. So very difficult to cope up in one lecture, cover all the things. Very difficult to take the lecture in a single lecture. I will try my best to one by one, and possibly, hopefully, I will not cover all the objectives today, and one by one in the next lecture I will cover up all the matters. So let us see how much I can cover today's lecture. So before going to the basics, let us introduce the cardiac conduction system regarding understanding, because the some of the newcomers and some of the old students, so I should go from the basics. The heart has an intrinsic pacemaker by its own. That is the Anode. All of you know that. And it generates electrical impulses that travel along a specialized conduction pathway. And this conduction process makes it possible for the heart to pump blood efficiently. So the circulatory system and the conduction system are absolutely attached with one another, and it should be synchronized. So one of the major functions of the conduction system is the synchronization of the action potentials and the contraction and relaxation function of the heart, so that the heart can pump the blood efficiently and properly. So before introduction, the electrical system, all of you know that this is the Anode arranging in the right atrium, and these are the internodal branches, and this is the AV node and the His bundle. And after the His bundle, it is divided in the lower part of the membranous septum, that is the right bundle and the left bundle. And the cardiac impulse originates from the Anode. When the atrium is full of blood, then it fires the signals, and it transmits to the internodal pathways towards the AV node, and the atrium, both the atrium contracts. And in the AV node, there is a delay. All of you know that the delay is due to the complete evacuation of the blood from the atrium to ventricle. There is the AV delay, known as the AV delay. These are all the very important functions for the also pacemaker regarding understanding. So the AV delay, and then the impulse passes through His bundle, and in the bundle of right bundle and left bundle. Left bundle is again divided into two fascicles, and right bundle is the single fascicle, and the cardiac depolarization occurs in the ventricle, and then after depolarization, all the blood propels through the pulmonary artery and the aorta to each. So these are the common things in the basic of the electrical system. If problem occurs in any system, that is the arrhythmia can occur in both the tachyarrhythmia and also the bradyarrhythmia. In case of bradyarrhythmia, if the problem occur in the impulse generation or any conductions of the system, then the impulse will not propel properly from the one chamber to the another chamber. So the blood will not expel properly from the one chamber to another chamber in the systemic circulation. So that will create the problem. So the problem may occur in the disorders of the impulse formation or generation, or the disorders of the impulse conduction may occur. So if this problem occur from the outside, we can artificially help the conduction system by making the cardiac pacing. So the artificial cardiac pacing is necessary then at this. And the external energy, what it does, that the external energy sources can be used to stimulate the heart when disorder in the impulse formation or conduction, leading to symptomatic bradyarrhythmia. And pacemakers are integrated systems that monitor cardiac rhythms as well as deliver electrical impulse to the myocardium. So it monitors this rhythm, own rhythm, and deliver the electrical impulse to the myocardium. Regarding history of the cardiac pacing, historically pacing devised in the 1950s and the alternating current power pacemakers tethered to the extension cord by the foreman, and is a huge pacemaker externally placed in 1950s. And then afterward there is the battery power transistorized wearable pacemaker done by the Lilhale and the Bacon. These are the historical matter. And in 1958, there is the main paradigm shift occur. The first fully implantable pacemaker implanted, that is by the Ilmquist and Senning. And the initial pacemakers are done by the cardiac surgeons and also the engineer. Engineers are also for the electrical engineers. So then the one by one, the paradigm shifts occurred and advancement of the 2015. This is the recent advancement of the pacemaker like this. That is the dual chamber pacemaker, and that had non-efficiently from the past. And in the 2016, this event is the leadless pacemaker. All of you know the coming days, these pacemakers are very promising, and in future also the batteryless devices which will come soon, their motion to power pacing circuits. And in these days, in the 1970s, the lithium iodide battery also introduced by the Wilson Greatbatch, and the dual chamber pacing was pioneered in the 1970s. And the rate responsive pacing, which is very popular nowadays, it is started and introduces in the 1980s. So these are before going to the details, some of the historical matters should know. I can go more faster, but I think that will be create more problem for understanding to you. So I'm gradually telling slowly. If it is a bit slow, let me know, please. So next is the components of the pacemaker system. So this is the recent pacemaker. So is the pacemaker generator, the connector, and the leads. The two leads. So it is the dual chamber pacemaker. So it looks like that. So what are the parts or components? That is the implantable pulse generator. This is the generator which contains the battery and the circuitry, and also in the connectors or header, and the leads. These are the leads, and leads having the cathode and the anode, that is the negatively electrodes and positively electrodes. Later on I will tell you what are these electrodes, and as well as the body tissues are involved in the pacemaker circuit. So the pacemaker components combine with body tissue to form a complete circuit to do its action. In pulse generator, inside it is a battery, and from which energy comes from, and it's sending the impulse to the heart, and the house of circuitry which controls the pacemaker operation. This is the pulse generator, recent, in which this company name of the company is already mentioned, and it is the mode is also mentioned, code is also mentioned, and here is also the in the header end there is connector. Upper one is the atrial lead connector, and lower one panel is the ventricular lead connector. So this is the recent pacemaker, and from it is made from the USA. It is also written in the pacemaker pulse generator. So the pulse generator is a titanium alloy shell. It's a hermetic sealing. It's a body fluid cannot enter into it, so the circuitry and battery cannot destroy. But it is a lighter, stronger, and it is non-allergic. And the screw, screwing can occur during implantation when lead is introduced inside the connector. So the pulse generator is the common battery composition include the lithium iodine, and the other components are the lithium silver vanadium oxide with carbon monofluoride. And the starting battery voltage will vary depending on the composition, in which material it will compose. And the longevity usually depends on the impedance and the output, how much energy it will giving, and how much impedance and resistance it is facing. It depends on the longevity, and commonly ranges the 6 to 12 years its life. So the battery life is the current drain, and is the 9.3 years average, 80,000 hours, and it is usually reliable. There is no premature failure occur. It's a highly technical electrical device and high volumetric energy density. So small battery volume with high storage capacity can generate impulses for the long time, low cell discharge rate, and high hermeticity, so no gas generation during operation. It is some of the characteristics of the pacemaker battery, and it has the battery volts, that is the beginning of life. They are around 2.8 volts initially when we implant the battery. It started its life gradually over the time, and depleted over the years, 8 to 10 years, and the volts it diminished to the 2 to 2.2 volts, and it will reach into ERI. This term is the elective replacement interval. So in this stage, we have to replace the battery, and it indicates that battery's life is gradually ending, and it will not work very long time. And as such, the monitoring is very essential for the patients, 6 monthly or yearly interval, to notice what is the ERI level, how much time it will take to work more, and if it is showing that the 2 or 2.2 volts around like that, so we will assume that the ERI will reach, and we will tell the patient to change the battery. And after the ERI, there is the more than 3 to 6 months. After the 3 to 6 months, the end of life will occur. After in this range, it is 1.8 volts around like that, the battery will not discharge any impulse. So it is the end of the life. It is a very grave condition. So before that, in ERI, we have to change our battery. So regarding leads, the leads are the insulated wires. These are the leads. So these are the insulated wires, deliver electrical impulses from the pulse generator to the heart, and sense the cardiac conduction, depolarization. What it senses, it also brings towards the generator. So leads, these are the leads, and in the leads, it has the electrodes in the tip, and the conductor, that is the main conductor inside, and insulation in the outside, and the connector pins in the back. The connector pin is there, and fixation system is there. So this is the leads. The outside, it is the insulator, and the tip is the conductor, tip and is the ring, and these are the fixation procedures, the tines and fans. Later on I will show you. So in the cathode, that is the negatively charged, which is in the tip of the lead. It is the electrode that is in the contact with the heart muscle, heart tissue. So it is negatively charged, and the anode in the positively charged, and it is not in the tip, and is the electrode that receives the electrical impulses after depolarization of the cardiac tissue. So once impulse passes towards the cardiac tissue, after depolarization, the impulse is sensed by the anode. So the body tissue and fluids are part of the conductor system, what I have told earlier. And so during pacing, the impulse begins in the pulse generator, flows through the leads and towards the cathode in the negatively charged, and stimulates the heart and returns to the anode, sensed by the anode. So the types of the lead is one is the endocardial or transvenous lead, and another one is the myocardial or epicardial leads. So let us see what are the endocardial transvenous leads. It is the two types transvenous leads, the passively fixed and the actively fixed. Passive fixation by the timed, it is the time, these are the times, and this is the passive fixation leads. The tines become lodged in the trabecular apex of the pectinate at the appendage of the right ventricle, where the meshwork of the heart tissues are originate. So it attached with this, and the active fixation, that is the screwing lead, and the helix or screw are inside the extends into the endocardial tissue. These are the helix or the screw in, allows the lead positioning anywhere in the heart's chamber. It is in the apex of the heart, in the trabecular pectinate, and the active fixation, you can do it anywhere by screwing it. So it is actively fixed. So some differences are there, the active fixation leads and passive fixation leads. The lead diameter is active fixation lead is smaller, and introducer size is also smaller, and lead tissue surface is doing by the trauma, but passive fixation lead is not doing any trauma, and the fibrotic ingrowth is slower, but it is faster, and repositioning at implant is easy, but it is also easy. Right ventricular application is usually less common. Active fixation is in the you can implant it anywhere in the RV, OT, and so nowadays is very commonly doing the his boundary pacing. In the lower part of the septum, you can actively fix the lead anywhere in the right ventricle. But in the passive fixation, you have to implant the lead in the apex more likely, other than it will dislodge. And in the atrial application, it actively fixation lead is very common, and the proximal manipulation is needed in active fixation lead, and chronic threshold is slightly higher. It will not that much important for you. And the epicardial leads, if the person is contraindicated for the transvenous lead, so in case of pediatric patients, and the patient's contraindicated, it is applicable by epicardial leads, it is a fixation by the epicardial stabbing, or myocardial screw-in or suture on by sternotomy or thoracoscopy, or limited thoracotomy. During cardiac surgery, surgeon can also implant these epicardial leads in the children's or pediatric patients. During lead insulators, two types of insulator are there. One is the silicon, very common, and polyurethane. In the newer bipolar lead insulation, both are present. Inside is silicon, outside is the polyurethane. Both are the inert component, and the biocompatible and biostable, and it is highly tear strength. It is very make it stronger in the leads. So in newer generation, both the insulator is there, and then the lead polarity. Lead can be unipolar or it can be bipolar. In bipolar, it is a larger diameter, it is a smaller diameter, but there's some advantages and disadvantages are there. In the unipolar lead, usually the cathode is in the tip and anode is in the can. I will show you later on. So the pectoral muscle stimulation can occur because the body muscle is involved in the system. But in the bipolar leads, the tip is the cathode, in the tip here is the cathode, and ring is in the outside the outside the helix in the bipolar leads. So here is the anode. It is named as the ring. So there is no involvement of the body tissue. So the my potential or the EMI or electromagnetic interference is less in the bipolar leads. So these are the two leads, and in the unipolar system, you see that the leads are here. The cathode is in the tip, and the anode is the can. So after stimulation of the heart, the impulse received by the body tissues passes through the body tissues and fluid received by the anode, that is the can is the anode. So contains a lead with only one electrode within the heart and another electrode in the can outside the heart. So the involve the other outer structures in the unipolar pacing system. In the bipolar pacing system, the lead is there and the electrodes are inside. Here is the cathode negatively charged and is the anode is the positively charged. So the impulse delivered and received inside the heart. So the outside interference is less. These are the basic difference of the unipolar and bipolar pacing system, and the nowadays, so the bipolar system are more popular. In the bipolar lead, differences are in the pacing, in the ECG, the pacing artifacts are small in the bipolar leads and very large in the unipolar leads, and pectoral stimulation is almost never in the bipolar leads, but the unipolar lead is possible. My potential interference is never in the bipolar lead, but it may be possible, and the size is larger. I have already mentioned smaller. These are the in the polarity, the two ways of pacing, that is the unipolar lead. So the cathode is outside and anode is in the can. So in ECG, the spike is very large spike, and in the bipolar lead, cathode is in the tip and anode is in the ring inside the heart. So the spike is very small. Nowadays, as such, the bipolar pacemaker very difficult to find it out the spike in the ECG, as all the pacemakers are the bipolar, and the artifact is very smaller. Pacing spike is very smaller, very difficult to identify. And so in this ECG, you show that in the lead 1 there is no pacing spike. In the VVI pacing mode is there. In lead 1 there is no pacing spike, but in lead 2 there is a small pacing spikes are there. And also in the V2 there is the pacing spikes are there, and also V4 there is the pacing spike, but other leads very difficult to find out that the spacing spike is present or not, very small. So very difficult to understand in the bipolar pacing system, as the stimulus is very small. And the new advancement, another advancement, is the leadless pacemaker. Nowadays all of you know that the lead is not absolutely not necessary in this pacemaker. Introducer sheath is there. Just we go into the transvenous route and we just enter into the right ventricle. This is the leadless pacemaker, and no intervention, very less amount of surgical procedure is necessary. So the percutaneous procedure, reduce hardware, no need of any generator, no need of any pocket, no need of any leads. So it is invisible to the patients. So the complication is very less, but some disadvantages also is there, because in leadless pacemaker there is no extraction system. So after the end of the life, we have to reintroduce another system, so the younger patients, multiple device you have to implant in the right ventricle. So these are the common disadvantages, drawbacks in the leadless pacemakers. So let us see the next step, that is the functions of the basic functions of the pacemakers. Am I audible clearly? Anybody can tell?
Yes, sir.
Yes, sir.
Any problem of any understanding or sound system?
No, sir.
Okay, thank you. So the pacemaker performs three basic functions. That is the pacing, sensing, and timing. These are the basic functions. And you have to understood all the functions one by one, because if we not understand the all the basic functions, very difficult to understand the total lecture, because the after completion of the lecture you have to understand all the things to do the program and to clinical implementation of the system. So one by one you have to understand, you have to concentrate more. Very difficult though, but I am trying. If any difficulties occur, you can ask me in any time. Otherwise everybody should mute, please. So the basic function is three, and other than functions, the four functions the pacemaker, most pacemakers perform the four functions. That is stimulate cardiac depolarization, and they sense the intrinsic cardiac function, and also respond to the increased metabolic demand by providing rate responsive pacing. And another important function is the diagnostic information stored by the pacemaker. You can store the pacemaker can store the information, and you can later on can print it and diagnose it. What is the problem? What the problem occur? The basic mechanism. Everything we can understand by the storing information. Let us see the one by one the functions. So the depolarization is one of the names is the capture. The depolarization of the atria and or the ventricles in response to a pacing stimulus. If we give the stimulus and the depolarization occur, this is known as the capture. If you give the impulse, if you give the impulse by the generator, but it will not capture, then it will not depolarization occur. And if depolarization not occur, the ventricle will not contract. So the capture is meant by the pacing stimulus along with the depolarization. So the since the pacemaker, it is another name is the output pulse. Output pulse is the commonly practiced in the Western country. That is the they are not telling the capture appears in the surface ECG. This is the output pulse. It's a very small vertical line known as the spike. So this is the basic. This is the VVI pacemaker. Later on, I will tell you what is the VVI pacemaker. But in this slide, you just show that this is the spike, pacing spike, and after that, ventricle will depolarize. This is the capture occur. And in a regular interval, that is the pacing interval, what we will fix in the pacemaker, it will pacing. So in the every pacing interval, it will pace the ventricle and depolarization occur. So this is known as the pacing intervals. I will tell you all the intervals and timing cycles later on. Gradually one by one. This is the basic, the pacing, every pacing interval spacing will occur and depolarize the ventricle. And the sensing is the another function, that is the ability of the device to detect intrinsic cardiac activity, whether any contraction, any P wave or QRS occur or not, the pacemaker will detect it. So the complications also occur. There is the undersensing and oversensing. That is I explained it in the previous lecture, my lecture, that is the pacemaker malfunction. But I will tell you in this lecture also, not that much elaborately, but a few. Here you will show that the pacing intervals, after the pacing spike, the depolarization occurs, the pacing interval will occur. But in pacing interval, if any internal intrinsic cardiac activity occur, then the pacemaker will reset the cycle, timing cycle. Absolutely, it is a timing. So it is called, here it is not the pacing. So it is the intrinsic bit, here it is not. Just observe, it sends the bit, no pace. So this is the sensing capacity. And again, it will, from this depolarization, it will again fix the timing according to the pacing interval. So from this level, again, it will, after a definite interval, it will pace and it will reset. As such, it is called as the escape interval. It is not the pacing interval. It is the sense bit. After that, it will reschedule its timing. So it is the pacing interval. It is not the pacing interval, it is the escape interval. So another thing is the chronotropic incompetence, that is the inability of the heart to increase. Another very important function nowadays, what I have mentioned earlier, the historical discovered, that is the 1980s, that is the rate responsive mode, that is the inability of the heart to increase its rate during exercise or during other metabolic needs. Inability to increase the rate according to the demand. So the consequence is the effort intolerance. It is known as the chronotropic incompetence. So it is the activity and it is the heart rate. If you resting state, if you start our activity, in normal cases, maximal heart rate will occur very sharply. And then a plateau state, activity continuing, and the plateau state will will stable in a plateau state, and after the stop of the activity, it is quickly in the baseline. If chronotropic incompetence occur, that is if you start the activity, you will not start that much with the normal, very slowly rise the heart rate, slowly gradually heart rate, and not a stable condition, ups and down. It is unstable, not a plateau status. So the patient will not that much taking the effort. It will up and down, and the patient will feel the complaint of the shortness of breath or effort intolerance, like that. And when you stop the activity, sudden it will fall, and that time somebody may fall or blackout may occur. So this is the chronotropic incompetence. The pacemaker will help it. When the need for oxygenated blood increases, the pacemaker ensures the heart rate increases to provide additional cardiac output. So in sleeping position is one heart rate, in sitting is another, walking, climbing, running, and again resting. All the sorts of activities pacemaker can observe and accordingly respond. And how it will respond? It is having the sensors. The variety of rate response sensors exist in the pacemaker. One is the activity sensors. Another name is accelerometer, that detect the physical movement and increase the rate according to the level of activity. And another one is the minute ventilation sensors that measures the change in respiration rate and tidal volume by transthoracic impedance readings. So these are the sensors. According that rate response sensor function is can be done by the pacemaker. So next topic we will see, that is the types of the pacemaker. What are the types? A lot of types are there, a lot of classifications are there, but some types, that is the asynchronous, that is the fixed rate. The pacemaker is in one fixed rate, it will pace continuously. And another one is the synchronous, that is the demand pacing. According to the demand, it will pace. And another classification is the single chamber or dual chamber sequential pacing. And another function is the types is the programmable or non-programmable. Let us see one by one. That is the main types is the single and dual chamber. At first we will see, we'll know what is the single and dual chamber pacemaker. So the single chamber pacemaker is very simple. That is a pacing lead is one pacing lead in the atrium or in the ventricle. So the pacing will occur in the one chamber, and sensing is also by the one chamber. So it is the single chamber pacemaker, one lead in the atrium or in the ventricle. Usually common in the ventricle. Very rare situations we have input the only atrial. So it may be used for patients in chronic atrial fibrillation, the VVI pacemaker, or in sick sinus. In the atrial sinus dysfunction is problem, and AV node in the lower part of the conduction system is okay, then we can implant a single chamber in atrial pacemaker. So that in atria pacemaker, it will generate the impulse and just carry on the AV node and the lower system as it is normal. So no need of any implantation of the ventricular lead. So it is known as the atrial chamber. There is the AAI pacemaker or VVI pacemaker. So ECG recognition, how we will recognize the ECG? That is in the A phase, that is pacing spike in front of the P wave, and there is no pacing spike in the QRS before the QRS complex. We will tell it is as a single chamber atrial pacemaker, the AAI or like that. Here it is there is no pacing spike in this complex, so it is sensed by the pacemaker. So it is AAI. When it is sensed, it will not pace. So here it is not pace. When rate is increased, pacemaker will sense it. When rate decrease, then it will pace. Okay. In the single chamber pacemaker in the ventricular lead, that is in the pacemaker, spike is there, followed by the ventricular depolarization. And here is the intrinsic bit, ventricular sense by the marker channel. It is the marker channel in the program, in the system when we program the pacemaker with the surface ECG. Just compare. If we compare, we will find it that here is pacing, ventricular pacing. Here it is ventricular sensing. So there is no pacing. Here again ventricular pacing, as there is no complex. Accordingly, it is a single chamber ventricular pacemaker. And some advantages and disadvantages of the single chamber pacemaker is there. That is, the advantages is very limited. The implantation of a single lead, manipulation is less, implantation procedure takes very less time, very easy to implant, complication is less. But disadvantages are there. There is a single ventricular lead does not provide the synchrony. That is the synchronization, which I have told earlier. That is the main function of the conduction system of the heart, because the circulatory system depends on that synchronization. So the atrial and ventricular synchronization, if not properly occur, the blood will not propel accurately from one chamber to another chamber. So this is the disadvantages. You are pacing only one chamber, so there is a disorganized. There is no organization, no synchronization will occur. And the single atrial lead does not provide the ventricular backup. If when needed, if you implant a pacemaker in the atrial chamber, if any time if we know this dysfunction or in the lower conduction system is arising any problem, develop any problem, so you will not pace the ventricle. So that time a catastrophe will occur. So these are some disadvantages. Let us see the dual chamber pacemaker. Very simple. There is one lead implant in the right atrium, another is the right ventricle. So this is the two lead system. Here in the we're showing there is the right atrial appendigeal lead and is the right ventricular apical lead. In the X-ray, it is the right atrial lead, is the right sided implanted pacemaker, dual chamber. The two leads are there. Two screwing the connector is observed, and the very difficult to understand, but one lead is here and another lead is in the right ventricle. So the dual chamber, one is the atrium, one is the ventricle. So in the spike, you will see before the atrium and before the ventricle. One spike is before the atrium, one is before the ventricle. So it means that it is the dual chamber pacemaker. It provides the AV synchrony and pacing support in both the atrium and ventricle if needed. Okay, so these are in dual chamber pacemaker. If you understand all the function in the timing cycles and the modes and codes, when I will describe all the topics, then you will understand the dual chamber pacemaker, how it will function, how can differently it will show its character. That is now I am telling somebody will cannot understand possibly, but later on I will make you understand. It is here is the atrial sensing, because one lead is in the atrium, it can sense, and one lead is the ventricle. So in atrial lead it can sense, it can pace. In ventricular lead it can also pace. So here atrial sensing occur, no pacing spike in front of the P wave, but in the spacing spike in front of the QRS complex. So it is atrial sensing but ventricular pacing. and it can occur in the atrial pacing and also in the atrioventricular pacing. Both are pacing spike is there, and in here the atrial pacing but no ventricular sensing, atrial pacing and ventricular pacing. And in this example you may show that the atrial and ventricle both are sensing, there is no pacing spike. So these patients are usually the case of the intermittent heart block. So they occasionally they are showing the normal conduction rate, and occasionally the conduction rate may be dropped down. That time pacemaker will work. When it is not needed, absolutely it is silent. So these are the dual chamber pacemaker function. When the heart rate is AV conduction is poor and slow, that time A pace, V pace is occur. When the normal or fast, that time essence and the atrial essence and V pace is occur. When the AV conduction is preserved and the slow rate, that time A pace and V sense, A pace and V sense, and the normal function and AV conduction is preserved, that time essence and V sense, no pacing spike is there. So the benefits in dual chamber I mentioned already, provides the AV synchrony, which is very important for the circulatory system, and the symptom, lower incidence of the atrial fibrillation, because if you put the pacemaker lead only in the atrium, it will pace, and it will exacerbate and irritate the atrium, and anytime atrial fibrillation can occur, and lower the risk of systemic embolization stroke because of AV synchrony. Anytime thrombus can go into the systemic circulation, and lower incidence of the new congestive heart failure, because if you pace the right ventricle chronic rate, so the right heart may fail. This is a problem nowadays. And the lower advancement of the pacemaker, that is the CRT, one lead in the right atrium, one in the right ventricle, another one is the left ventricle to the coronary sinus, and most chronizally, so that the synchronization occur in both the right and left ventricle occur and propel the blood properly and effectively. So this is the pacemaker of the triple chamber, triple lead, and this is one lead is in the right atrium, one lead is the right ventricle, and another lead is in the coronary sinus, through the coronary sinus in the left ventricle. So this is the CRT pacemaker. Next we show the pacemaker node. Is there a time mode? Okay, I will skip a little bit, possibly that will be so some electrical concept regarding the pacemaker. It is very essential to understand because it is an electrical device, so that we have to understand all the electrical concepts, the stimulation process and the sensing process, and also the electrical pacing circuit has the following characteristic. That is the voltage, the current, and the input through a circuit. And in a pacing system, voltage is measured in volts. Battery will provide the push or voltage or force, often referred to as the amplitude. And current is the flow, that is the force, and it is the flow of the electrons of a complete circuit. And in a pacing system, current is measured in the milliampere and represented by the letter I and determined by the amount of electrons that move through. The voltage is the force of the current. And the impedance is the opposition of the current flow. That is the barrier or the resistance it fills. So in a pacing system, impedance is measured in ohms, represented by the letter R of W, the measurement of the sum of the all resistance to the flow of the current. So it is the impedance or resistance what is facing the pacemaker electrical system. So Ohm's law is a fundamental principle of pacing. We have to all understand that is Ohm's law that describes the relationship between the voltage and the current and the resistance. So main understanding is the voltage is the, so any calculation can occur through these Ohm's law. We can measure the voltage, we can measure the resistance, we is directly proportional to the current if the resistance isn't. Okay, so if the voltage remains constant, if the voltage decreases, current also decreases. If the voltage constant, the impedance decreases, current will increase. So it is the clinical management of the, and the current decreases and the impedance decreases, current will increase. So this is the understanding of the impedance. That is in the normal resistance, the friction caused by the hose pipe. This is the example commonly given. You have already possibly noticed that this example, that is the hose pipe and the nozzle. The normal resistance is the hose pipe and the nozzle is there. So the fluid or water is passing through a definite resistance. Fluid is passing through the hose pipe. If the resistance is low, that is the in a leak in the pipe is occur, then the fluid or leak through the pipe, and the tank will need supply the more water to the nozzle, and the fluid will leak through the pipe. In case of to the lead with insulation break, which results in the low resistance will be low because the current will drain through the pipe, through the lead. So if the insulation break, current will pass through the lead, and the pacemaker will supply more energy, and the resistance will low. So the pacemaker will have to push the more energy. So pacemaker life will depleted earlier. And if you not results in the low total current flow, then the knot is there. If you block the pipe, so the water will not go to the nozzle, and the resistance will show a large, high resistance will show. Similar to the pacemaker, if the lead is broken or total conduction is broken, then the pacemaker will show the very high impedance, and it will not deliver the impulse to the cardiac muscle, so it will fail. So these are the very devastating conditions. We have to understand in the by looking the resistance, by observing the resistance, observing the current, we can assume that the any problem in the lead occur or not. So a fracture conductor, here is the pacemaker, and conductor is absolutely fractured. So it will show the very high resistance, no impulse will passing from the generator, very high current in drain. So fractured wire can cause impedance values to rise. Very high impedance it will show, exceed more than 3000. So the current flow from the battery may be too low to be effective. Energy will not pass through the lead. Other reason for high impedance is the very loose connection of the lead in the header during the implantation. This is another common acute problem after the implantation. And if the insulation break, here the insulation break, and the insulation break can cause the impedance value fall. Impedance will fall because the current will drain through this way, and current is high and can lead to more rapid battery depletion. Current drain through the insulation break into the body and the other lead, not through the myocardium. So less than the 300, very low impedance will show, and we can understand that the insulation break can occur. So the factors that influence the impedance, the resistance of the conductor coils and the tissue between the anode and cathode, electrode and microgrill interfaces, size of the electrodes, size of the electrode surface area, size and shape of the tip. These are the factors influencing the impedance. So let us see the impedance changes affect pacemaker. What I have told, that the impedance changes affect pacemaker function at battery longevity. So the high impedance reduces battery current drain and increases longevity, and the low impedance increases battery current drain and decreases longevity. Values range normally from the 300 to 1500 watt. The high impedance leads will show impedance values greater than 1000 ohms even. So factors that affect the battery longevity include the lead impedance, amplitude and pulse width setting, and the percentage paced versus intrinsic events. How much the pacemaker we have to pace, and how much intrinsic events it will sense, and rate responsive modes on or not. If the mode is on, the pacemaker battery longevity will deplete earlier. So some example of the Ohm's law, that is, if you reduce the voltage by half, the current is also cut in half. If you reduce the impedance by half, the current doubles. If the impedance increases, the current decreases. So these are some examples according to the Ohm's law. Some are the I is equal to V by R, or V, so we can measure it from the, if it is given, the voltage is given, impedance is given 500 ohms, so current we can measure by using this formula. So a few time is there because I have started 1:15. Okay, shall I stop here? Shall I stop here, or
Yes,
more?
sir.
Because 1 hour is finished.
Yes, sir.
হ্যাঁ, হ্যালো,
আজকে স্টপ করে দেন স্যার। আর
হ্যাঁ, আমার তো মনে হয়, হ্যাঁ, কারণ অনেক লং টপিক, এটা নেক্সট সেশনে নিতে হবে। হ্যাঁ,
জি স্যার।
বাকি একটা করে ভাগ করে নিতে হবে এমনি। তাহলে কোনো কোশ্চেন, এনি কোশ্চেন?
Thank you for your excellent class, sir. My question is, sir, by seeing the ECG, sir, how we can predict what is the site of pacing? Sometimes sir are asking the possible site of pacing.
Site of pacing.
Site of pacing, sir. Whether it is RB pacing or high septal pacing or CRT pacing, sir. What are the ECG?
Okay. We can assume that where the pacing is occur by observing the pacing spike. The initial basic is if it is in front of the pacing spike, is in front of the ventricle or atrium. It is one criteria. That is in front of atrium, it is atrial pacing. In case of ventricle, before the ventricle is ventricular pacing. And if it is the location where the RV apical or RV septum or the LV pacing, these are the different another character and criteria. By observing not only the spike, it is the more advancement for the today's lecture. But if you ask this question, I am telling that if you, by observing the axis, by observing not only the spike should be present in front of the ventricle or in front of the atrial depolarization, but by observing the sorry, my phone is coming. By observing the axis of the ECG, we can assume that where the pacing is occurring. Because if you put implant the RV apex, so the impulse will you will depolarize the RV in the apex, and in the lower part of the lower side of the heart. So in ECG, 2 and 3 lead is in the lower side, directly toward the lower side. So if you pace the heart, pace the RV in the apex, depolarize towards the lower side. If you see that, if it is depolarized the lower side, if you depolarize the lower side, so in the 2 and 3, it will be negative. If it is negative, so we will assume that it is RV pacing. If you implant the RV lead in the septum, the axis will change, because in the septum is the higher part. Or if you implant the pacemaker lead in the RVOT in the upper part, that time the pacing axis will absolutely change, because you are pacing the heart from the upper side. If you're pacing the upper side in the 2 or 3, it will be in the positive. So the axis will be changed. So by observing this, we can assume that it is high RV apex or in the RVOT or in the septum. And another question is how can we understand the BIV or LV pacing? If you look at the LV pacing, so the axis is also changed. Some of the ECG features are there, because that is we will put the one lead in the RV, but we will not pace the RV first. We will pace the LV first. So our target is synchronization, LV first, then RV. So LV pacing will first occur, and then the RV pacing will occur. So you will show the axis will change, and you will see in the V1 the chest lead when the depolarization occur in the fashion of the RBBB morphology. If it is RBBB morphology in the chest lead, we will assume that LV is pacing earlier. You will pacing the LV. Never you will pace the RV. It will never be in the chest lead. It will never be in the RBBB morphology. So by observing the axis, it is advanced in today's lecture, possibly not understandable for all
sir,
the
thank you very much, because in our NICVD, in the CCU receive patient with CRT or biventricular pacing, sometimes motion sensor call us and ask whether what you are seeing in the B1. We cannot say anything. That's why sir, I'm asking this.
Oh, sure. If I will tell you in the next class, because I will not completing all the lectures, all the topics. Very interesting. The next lining cycles, even I'm be able to understand how the pacemaker will act, how the pacemaker will function, because it is very necessary for the understanding. Otherwise, only basic, it is also including the basic. Otherwise, you will not understand what are the indications and how it is working. And the today's your question answer, you already understand what I have told?
Yes, sir. Thank you, sir. It's very much clear, sir.
Okay. Anything else more?
Yes, sir. Assalamu alaikum, sir. I'm Dr.
Sorry. Can you mention your name again?
Yes, sir. Yes, sir. NICVD.
হ্যাঁ।
স্যার, একটা প্রশ্ন ছিল যে আমরা যখন পেসমেকার করি,
জি,
পেসমেকার করলে আমরা থ্রেশহোল্ড যা পাই, আউটপুট তার 2 দিয়ে গুণ করে 1+ যোগ করে রেখে দিই। মানে 1 যদি 1 পাই, তাহলে 3 এ রাখি।
হ্যাঁ,
এই ফিক্স এটাই কেন স্যার? 3 এ রাখি।
হ্যাঁ, ঠিক আছে, আমি বুঝতে পারছি আপনার কোশ্চেন। এই জন্যই বললাম যে এই বেসিক একসাথে হবে না। হ্যাঁ, আমি জাস্ট পরবর্তী যেই টপিকটা শুরু করতে চাচ্ছিলাম, যে এই পেসিং থ্রেশহোল্ড, এই টপিকটা বললেই আপনি কিন্তু এই ব্যাপারটা ক্লিয়ার হয়ে যেত। তারপরেও আপনি যেহেতু কোশ্চেন করছেন, যেটা আপনাকে বলতেছি, পেসিং থ্রেশহোল্ডটা ডাবল, ট্রিপল এরকম করে আমরা রাখি এই কারণে, because of the safety. If anything occur, any emergency occur, anything may hamper or interfere the pacing threshold, that time pacemaker can be able to pace. As such, we will make it twice or thrice than the normal, the minimum range. There's 2 or 3 slide later on, I will explain it properly. so that you can understand. But the initial answer is like that. So for the safety purpose, we will fixed it a more higher range, twice or thrice than the minimum range, so that it can, in emergency, in case of any fall of any threshold, it can generate the impulse or output pulse capture can be given. So this is the reason. Understand? Anything else?
Thank you, sir. Sir, Dr. Konok বলছিলাম, sir, NICVD resident.
হ্যাঁ হ্যাঁ, কনক বলো।
So thank you for your nice, thank you, sir, for your nice and colorful presentation and very informative. I think for a novice like me, sir, আপনি dual chamber pacemaker ফাংশনের ওখানে যে ইসিজিটা স্যার ইসিজি দিয়ে স্যার বুঝাইছিলেন স্যার, ওইটা একটু স্যার কনফিউশন, স্যার আমাদের কাছে কনফিউশন, আমার কাছে কনফিউশন লাগছে।
বললাম as you are newer, আমি কি আবার দেখাবো?
স্যার একটু, স্যার যদি একটু ক্লিয়ার করতেন স্যার, স্যার যে কখন এট্রিয়াল সেন্সিং, ভেন্ট্রিকুলার পেসিং, স্যার এই মোডটা একটু স্যার যদি স্যার ডুয়াল চেম্বার পেসমেকার ফাংশনে যে স্যার ইসিজি দিয়ে যে আপনি এক্সপ্লেইন করছিলেন স্যার, স্যার ওটা স্যার
ও মাই গুডনেস, হ্যাঁ করতেছি, রাখো। না আমার এটা মনে হয় চলে গেছে না
স্যার, আবার শেয়ার দিলেই
দাঁড়াও। ক্রস করে ফেলছি তো এই জন্য। ওই কোডস্টার মোডসটা কনক, কোডস্টার
জি স্যার
শেয়ার হয়েছে, শেয়ার হয়নি এই তো না?
না স্যার শেয়ার হয়নি,
শেয়ার করতেছি, রাখো। হ্যাঁ শেয়ার হচ্ছে, এখন শেয়ার হয়েছে।
জি স্যার, জি স্যার শেয়ার হয়েছে।
হ্যাঁ কোডস্টার মোডসটা কিন্তু তোমার আমি করি নাই, এটা তোমার ছোট করব কিভাবে। কোডস্টার মোডসটা আমি বলি নাই যেহেতু আজকে, এই কারণে তোমাদের এটা বুঝতেই হয়েছে, কিন্তু কোডস্টার মোডস তো এখনই বলতেছি আমি। রাখো। হ্যাঁ হ্যাঁ
জি স্যার, ডুয়াল চেম্বার পেসমেকার ফাংশন স্যার পরের ইসিজি দিয়ে স্যার যেটা বলছিলেন স্যার, এর আগে স্যার
এইটা। হ্যাঁ
জি স্যার,
এটা তো
এর পরের স্যার, এর পরের স্লাইডটা স্যার, পরের স্লাইডটা ইসিজি দিয়ে
একই আগের যে স্লাইডটা দেখাইছি, এই স্লাইডটারই এটা কন্টিনিউয়েশন, যেটা আমি তোমাকে যেটা বলতেছিলাম, যখন সাইনাস রেট স্লো থাকবে, sinus rate slow and AV conduction is poor, sinus rate is slow, that time atrial pace, AV conduction ও poor, তখন ventricle ও pace, কাজে A pace V pace, understand? যখন sinus rate normal or fast, তখন atrium কে pace করার দরকার নাই, তখন A sense, কিন্তু ventricle এর AV conduction is poor, এই জন্য ventricle pace, understand? বুঝতে পারছো? সাইনাস রেট নরমাল অর ফাস্ট, এই জন্য পি ওয়েভ নরমালি আসতেছে, দেয়ার ইজ নো নিড অফ এনি পেসিং, বাট এভি কন্ডাকশন ইজ পুয়ার, সো ভেন্ট্রিকল ইজ পেসিং, আন্ডারস্ট্যান্ড?
জি স্যার,
এইটাকে দেখো, সাইনাস রেট ইজ স্লো, এভি কন্ডাকশন ইজ প্রিজার্ভ, মানে এভি কন্ডাকশনটা নরমাল, কিন্তু সাইনাস রেট স্লো, তার মানে কি এভি নোড নরমাল, শুধুমাত্র অ্যাট্রিয়ামটা স্লো, সাইনাস রেট স্লো, কাজে ইউ হ্যাভ টু পেস অ্যাট্রিয়াম, কিন্তু এভি কন্ডাকশন নরমাল, এই কারণে ভেন্ট্রিকুলার কোনো পেসের দরকার নাই, শুধুমাত্র অ্যাট্রিয়াল পেস, ভেন্ট্রিকুলার সেন্স, আন্ডারস্ট্যান্ড কনক?
জি স্যার, জি স্যার।
এইবার দেখো এইটাতে, এইবার দেখো নরমাল আর সাইনাস রেট নরমাল, এভি কন্ডাকশন নরমাল, কাজে নো নিড অফ এনি পেসিং, এ সেন্স ভি সেন্স, এই জন্য ডুয়াল চেম্বার পেসমেকারের এটা হচ্ছে একটা ফ্যাসিলিটি, যেটা আমি মোড যখন পড়াবো সামনের লেকচারে যখন কোডস এন্ড মোডস বলবো তখন এটা আরো বেশি ক্লিয়ার হবে। এখন ডুয়াল চেম্বার বলতে গেলে ডুয়াল চেম্বারের কিছু ইসিজি এক্সপ্লেইন না করলে তো তোমার আগানো মুশকিল। হ্যাঁ, এই কারণে আমি এটা এইখানে কিছু বলছি, কিন্তু আমি তোমাদের আমি মনে করি যে নেক্সট লেকচারে যখন আমি কোডস এন্ড মোডস বলবো তখন দেখবে ইট ইজ সো ইন্টারেস্টিং এবং কত ক্লিয়ার ব্যাপারগুলি মনে হবে যখন এই জিনিসগুলো ডিফিকাল্টি থাকবে না। আমি এখন যে বলছি কনক তুমি বুঝছো 4টা মোড ডুয়াল চেম্বার 4টা ভাবে রিঅ্যাক্ট করতে।
জি স্যার, স্যার কিছুটা ক্লিয়ার হয়েছে স্যার। স্যার
এখনো বলতেছে কিছুটা ক্লিয়ার, আর কেমনে ক্লিয়ার করব তাইলে?
না স্যার, না স্যার, স্যার আপনি বলেন যে
তাহলে নেক্সট ক্লাস,
স্যার আপনি বলেন জি স্যার
নেক্সট ক্লাসে। তাও আমি মনে করি যে বাকিরা কি সবাই ক্লিয়ার আমি যেটা বলছি? আর কারো কোনো কোয়েরি আছে ডুয়াল চেম্বার পেসমেকার ফাংশনটা বুঝতে? আর কারো বাকি নাই? আমার মনে হয় সবাই বুঝতে পারছে। কাজী আর কারো কোনো কোশ্চেন না থাকলে আমরা তো আমি মনে করি এই করতে পারি। হ্যাঁ, আর কেউ কি কোনো কোশ্চেন আছে? আজকে মনে হয় রুবন অ্যাটেন্ড করে নাই নাকি?
স্যার রুবন ভাইকে দেখি নাই।
হ্যাঁ, সেটাই আমার তো মনে হয়। আচ্ছা, আমার মনে হয় যে আমরা শেষ করে দিই। আর কারো কোনো কোশ্চেন না থাকলে আমি
একটা কোশ্চেন
কনক্লুড। ওকে, জুবায়ের
স্যার। স্যার ওই ডুয়াল চেম্বার পেসমেকার যেটা স্যার এসেন্স ভি সেন্স, স্যার যদি আমার পেসমেকার একটা পেশেন্ট যদি হিস্ট্রি না থাকে, মানে আমি যদি হিস্ট্রি না নিয়ে থাকি স্যার পেসমেকার লাগানো আছে কিনা স্যার, তাহলে নরমাল ইসিজি এবং এই এসেন্স ভি সেন্স এটা কোন ডিফারেন্সিয়েট করতে পারবো স্যার?
ডিফারেন্সিয়েট করতে পারবেন না। ভেরি গুড কোশ্চেন আমি মনে করি ফর আন্ডারস্ট্যান্ডিং। হ্যাঁ, ভেরি গুড কোশ্চেন। আপনি যদি হিস্ট্রি না নেন, পেশেন্ট যখন এসেন্স ভি সেন্স মোডে থাকবে তখন ইউ ক্যান নট ডিফারেন্সিয়েট whether it is a pace beat or not, pacemaker is implanted or not, otherwise you will whenever you will have to the history of the pacemaker, otherwise you cannot differentiate.
থ্যাংক ইউ স্যার।
থ্যাংক ইউ। তাহলে আমার মনে হয় যে আমরা একটু লিভ করি। হ্যাঁ, আজকের জন্য।
জি স্যার।
নেক্সট এর পরে আমি মনে করি যে লেকচার বাকি রইলো, এটা তো নেক্সট ইসে নিব আমি। আপনাদের মনিটর কে রুবন না?
হ্যাঁ স্যার।
হ্যাঁ, ঠিক আছে।
হ্যাঁ স্যার, রুবন ভাই।
ওকে, তাহলে আমি মনে করি আমি এন্ড করলাম। থ্যাংক ইউ ফর ইউর ভেরি ডিফিকাল্ট টপিক বাট ভেরি your patience, understanding and hearing. So hope for the best for the next lecture. Thank you very much.
Thank you sir for your